Good afternoon, ladies and gentlemen. It's very honor for me to welcome you to the Cardiovascular Disease and Screening webinar in collaboration with University of Munster, Germany. Today's session will provide you with a comprehensive understanding about cardiovascular disease and screening with eminent speakers from the University of Munster and also several speakers from Indonesia. And before we proceed, I would like to introduce myself. My name is Dimas Septian Eko Wahyu Sumunar, and I'll be your Master of Ceremony during this session. And now, we would like to start by viewing an introduction or opening remarks from Professor Laksono Trisnantoro. Professor Laksono Trisnantoro is a professor in the Department of Health Policy and Management, Universitas Gadjah Mada. He is graduated from medical doctor program in 1980 and continuing his education in Master of Science in Health Economics at Department of Economic, University of York, United Kingdom. In addition to that, Professor Laksono earned his doctoral degree in London School of Hygiene and Tropical Medicine with a specialization or in a joint program between the LSHTM and also the London School of Economics from University of London, UK. And since 2001 and 2002, he enrolled in a doctoral program, postdoctoral program at Harvard Medical Schools. And now we would like to follow the opening remarks from Professor Laksono Trisnantoro.
Good morning and good afternoon, ladies and gentlemen. The Center for Health Policy and Management, Faculty of Medicine, Public and Nursing, UGM, proudly presents webinar. The title is Screening on Cardiovascular Disease, a knowledge sharing by University of Munster, Germany, and Universitas Gadjah Mada, Indonesia. This is Tuesday on the 4th of June, 2024. And this is the first knowledge sharing event by Universitas Gadjah Mada Indonesia and University of Munster, Germany. And for this event, many thanks to the Ambassador of Indonesia for UNESCO, His Excellency Professor Ismunandar. He inspired us to organize this important meeting. Also for Professor Ova Emilia, Director of UGM, and Honorary Council of University of Munster. Many, many thanks. And if you look at why we organize the event using screening as the main theme, and the following event will be screening in ENT, in eye problems, and also diabetes and other major health problems. But why screening? First of all, screening is very important for controlling the rapid increase of hospital treatment. And this means that the cost of hospital treatment is also becoming, like we call it, catastrophic for Indonesian economy. So we have to control. And that screening is also becoming a cornerstone in the healthcare transformations in Indonesia. So if we look at the data of the National Health Insurance or BPJS claim, then we can see that there is a rapid increase of hospital expenditure or claim by BPJS is sharply increased in Region 1 in Java, but flattening in province outside of Java, especially in Papua, Maluku, Papua Barat, and also Maluku Utara. So that means we have to be very, very cautious or maybe worried about the increased cost of hospital treatment. So that's why screening is needed. Also, screening position is strategic in Indonesian health system transformation 2021-2024. So here is the cornerstone, and it's becoming the first things that we have to do in terms of preventing people for not being sick or becoming worse in terms of health status. So screening is very important in Indonesia health system transformation. Many thanks for all speakers and moderators, for Professor Dr. Lucia Kris Dinarti, Professor Dr. Dr. Rasjid, Soeparwata, Professor Gerhard-paul Diller, Professor Matthias Sigler, and the moderator Dr. Dia Wulan Anggraini. Please enjoy the discussion. Thank you very much.
Thank you very much, Professor Laksono, Trisnantoro, for your insightful remarks. And now, ladies and gentlemen, we would like to proceed with the main session within this webinar, and would like to invite Mrs. Dia Wulan Anggraini, medical doctor, PhD, cardiologist consultant, and she is currently serving as cardiologist consultant within the Cardiology and Vascular Department, Faculty of Medicine, Public Health and Nursing Universitas Gadjah Mada. And he graduated from cardiologist program, Universitas Gadjah Mada in 2014, and in 2019, she is earning her cardiologist consultant at Harapan Kita National Heart Center, Jakarta. Without further ado, now I would like to invite Mrs. Dr. Dia Wulan Anggraini to guide this main session. To Dr. Dia, time is yours.
Thank you. First of all, I would like to thank Prof. Laksono from the Health Policy and Management and UGM that holding this webinar in this afternoon about cardiovascular disease and screening. And I think the idea of Prof. Laksono is very bright, that we have to emphasize or strengthen the screening in cardiovascular disease, since the high burden of the disease itself in our country, and also the high burden in the national health insurance. And in this particular afternoon, it's very happy that we have all these distinguished speakers. We will have two from Germany and one from our institution itself. And we will have three speakers talking about the general overview of congenital heart disease. And the second speaker from Germany will talk about the screening. And the third is from our institution. Prof. Lucia will talk about the situation of screening in our country. And we really hope that this afternoon webinar will have an impact for everybody who joined this afternoon webinar about the impact of screening in the future prevention of the cardiovascular disease. In particular, how should we manage and decrease the morbidity and also mortality in patients with congenital heart disease from the childhood to adulthood. And also, we hope that we have the mutual collaboration in the future with University of Munster, Germany, because we probably share some similarity and also have differences in the characters of patients. So in the end, it will be for the sake of our patients. So without further ado, we will have the first session for the general overview on the care of patients with congenital heart disease as a long life disease, that will be given by Professor Gerhard-paul Diller from University of Munster. Prof. Diller is a consultant cardiologist and professor at the Division of Adult Congenital and Valvular Heart Disease, Department of Cardiovascular Medicine, University Hospital Munster, Germany. He's also a visiting professor in National Heart and Lung Institute of London. And yeah, he's one of the author in the European Society of Cardiology guideline for adult congenital heart disease. And we really would like to learn from him about the spectrum of congenital heart disease as a long life disease. So is Prof. Diller here already? Join in the Zoom? Yeah, I think he's there. So Prof. Diller, I would like to please you to have your time for about 15 minutes for the lecture. Uh, Prof. Diller, can you hear our voice?
Hello, everyone. I hope you can hear me. I don't know. I have a slightly unstable internet connection, despite the fact that I'm in the hospital and the university Wi-Fi, so it should be actually good. But it seems to be very temperamental this morning for some reason. So I missed the last sentences that you said, but if it's okay, I would
Yes.
start my presentation now, if it's okay for everybody.
Yes. Yes,
Okay,
please. It's your time now to
Thank
deliver
you.
your lecture.
Sorry for that, and I hope the internet connection is sort of okay. Thank you very much for having us and having me. It's a great pleasure to be part of this distinguished panel and to discuss and give my or our views on the general care of patients with congenital heart disease, which I think everybody will agree is a very important disease with a lot of morbidity and mortality, and is also a lifelong chronic condition that is a particular challenge for healthcare systems everywhere in the world. So congenital heart disease is a very common condition. It's actually the most common inborn defect in humans. There are various estimates about the incidence of congenital heart disease, and they all agree that approximately 1 in 100 newborns has some form of a heart defect. It's of course most conditions, if left untreated, have a high mortality. What makes it of course challenging is that it's a very heterogeneous spectrum of disease. There is a variety of diagnoses, some of them very severe, some of them maybe more benign, that require a lot of expertise on behalf of our pediatric cardiology colleagues, cardiac surgeons, and later on the adult cardiologists to treat this condition. We tend to think that congenital heart disease is a phenomenon of our time, but in fact, of course, it has been around for a long time. There are some very interesting papers that show that historic archaeological data and papers that show that people used to have congenital heart disease even in prehistoric times. On the right, you can see a transcript of a papyrus from Egypt 3,000 years ago or 5,000 years ago, which says the patient has, or a person has, cyanotic lips. And on the left-hand side, you can see from ancient Rome or pre-Roman times, Etruscan grave, a patient with aortic coarctation, so a narrowing of the aortic of the descending aorta, which then left to this changes on the ribs of this patient. So it's not necessarily a completely new disease. It used to exist. This is a self-portrait of a famous Dutch painter, Dick Cat, who had a particular form of cyanotic congenital heart disease, the trilogy of Fallow, who did this portrait 100 or so years ago. And you can see the signs of cyanosis, his blue lips, his changes on his fingers. So this type of disease existed throughout history. But of course, until the advent of congenital cardiac surgery and pediatric cardiology, some 60 or 70 years ago, the vast majority of these children that were born with congenital heart disease used to die very early after birth. You can see this survival curves on the left-hand side, historic data from the 1970s, and you can see for complex conditions like transposition of the great arteries or tetralogy of Fallow, there is hardly a patient here that survives past childhood. Here's the age of 20, so less than 10%. So most of these kids would die very early in childhood. And only then in the 1940s, 1950s, and with the advent of the heart-lung machine in the 1960s and the progress in cardiac surgery, these children could survive into adulthood and live a fuller and a longer life. And this is, of course, the cohort that we are faced in with in most countries now. And this is just to illustrate the natural history of congenital heart disease based on historic data. Progress in cardiac surgery, only 15%, it's estimated that only 15% of children born with congenital heart disease would survive to become adults. These days, in most Western countries, it's more than 95% of patients who would survive to adulthood. And of course, this is a testimony to the progress in pediatric cardiology with better diagnostics, including echocardiography, invasive diagnostics, invasive interventional procedures, but mainly, of course, the colleagues from cardiac surgery who developed a number of surgical procedures that enable these patients to survive the pediatric period. And so we see this progress, and we have to attest that congenital heart disease is really a prime example of disruptive innovations, where you took a cohort of patients that untreated were basically doomed to die in early life and transformed the life of these patients. Over 95% of these children now surviving to adulthood. So it's one of the big success stories of cardiovascular medicine, really. And what we see now is, of course, a transformation in the spectrum of patients with congenital heart disease that used to be an entirely pediatric cohort where we had only children with congenital heart disease because they would, most of them would die in childhood, to a spectrum where most patients survive to adulthood, and that changed the complete composition of congenital heart disease. And now in Western countries, we have more adults with congenital heart disease alive than children with congenital heart disease. And this difference is proposed to increase as more and more patients reach adulthood. So this is data from the German National Registry for Congenital Heart Disease, looking at patients with congenital heart disease. As you can see, the green bars are the children with congenital heart disease. The blue bars are the adults with congenital heart disease in Germany. And as you can see, around 2005, we had an even number, so as many children with congenital heart disease as adults, and now we have many more adults with congenital heart disease than children. So, of course, the workload for pediatric cardiology as such is not going to change, but if you think about healthcare provision and congenital heart disease as a lifelong disease, you need to be prepared to have a large number of adults with congenital heart disease that will come your way and will need to be you need to be cared for. And so a couple of years ago, we wrote this paper with some eminent colleagues from Europe and Canada and the US to highlight this issue that congenital heart disease is a chronic lifelong condition, and that you need to have a lifespan perspective on the condition, starting from fetal life to old age in these patients. And you can't see this as an isolated disease. The problem is that, or the good thing is that the vast majority of patients with congenital heart disease, if discovered early and treated by pediatric cardiology and cardiac surgeons, will survive to adulthood. But the downside, of course, is that these patients are not cured. They will have a lifelong chronic conditions, and there will be issues throughout life. There will be issues with heart failure, with neurological issues, with sudden cardiac death, arrhythmias, pulmonary hypertension. There will be large issues, and I will show you a few slides on that, about pregnancy in these patients. Many of these patients will have reduced life expectancy. And on top of that, you will get acquired cardiovascular conditions in many of these patients that will complicate things further. So this is a condition that requires lifelong specialized care, and these patients are by and large not cured by the initial operation. We also have an increasing number of ACHD patients over the age of 60. This is data from the Royal Brompton Hospital in London that we published a decade ago, showing the increase of ACHD patients or congenital heart disease patients who are older than 60 years old. And this is also a population that is going to increase. And you can imagine that these patients will present with a number of problems on top of their congenital problems. They will have acquired heart disease. They will have chronic conditions, as many people have. And they are a particular challenge. And of course, these patients are not only challenging in terms of medical issues, but also very resource intensive and very costly to treat. So I think we agree that this is a chronic condition that needs to be cared for throughout life. And in most Western countries, provisions have been made to look after these patients throughout life, starting with pediatric cardiology, continuing with adult congenital heart disease, care provided either by trained pediatric cardiologists or by trained cardiologists. And even in resource-rich countries like Germany or the UK or the US or Canada, we have the issue that many of these patients are lost to follow-up. This is data that we looked at in Germany, and we found in a nationwide of a patient with congenital heart disease that only half of these adult patients with congenital heart disease are actually cared for by a cardiologist. Despite the fact that in Germany care is free at the point of care for most patients, so they don't have to pay for their care, but even in this scenario, half of the patients are lost to follow-up. And we also found that these patients that are not cared by cardiologists have a worse survival in this population. So it's an important issue to keep these patients under follow-up, but unfortunately, half the patients are lost to follow-up. This is data from Canada. Looking at this particular issue, as you can see, starting from the age of below 6 years of age, patients with congenital heart disease, there is attrition throughout pediatric care, and almost 50% of the patients are lost to follow-up by the time they reach adulthood, reach an age of 18 to 22 years of age. So we have a big issue here of loss to follow-up and how to keep these patients under regular follow-up. This is again to highlight what I said initially. These patients are not cured by the initial operations. This is data from the Royal Brompton Hospital, again looking at mortality rates across the spectrum of congenital heart disease. And if you look at the right-hand side, the SMR, that's a relative mortality ratio compared to a age and gender matched general population. As you can see, the complex conditions here have mortality rates that are 10 to 20-fold higher than the general population, despite the care that we provide in childhood. So this is a condition that is not cured. This is a condition that requires lifelong care, and despite this lifelong care, they have a higher mortality rate. And there are a number of reasons why these patients die, but the main issues in our cohorts in Europe and North America are heart failure. That's the yellow bars. Sudden death is a large issue. So arrhythmias and sudden death is a large issue. There are other conditions like pulmonary hypertension that lead to mortality. What is not so much an issue these days is perioperative mortality in these patients. So of course, these patients require multiple reoperations, but the mortality in this patients is very reasonable in the current era. And as these patients grow older, projected numbers suggest that heart failure will become a big issue in these patients. So that we're looking at a heart failure epidemic in congenital heart disease. And this is a big challenge because we do not have good tools to treat heart failure very well in this population. This is a slide that comes from Jane Somerville, one of the big personalities in congenital heart disease, looking at the time of death in patients with congenital heart disease. And it echoes what I said before, is in the early era, almost all of the patients with congenital heart disease died in early childhood. Now we're looking at a population that is surviving to adulthood and having problems in late adulthood and dying of various reasons, mostly chronic reasons like heart failure and arrhythmias. Cardiac death is a big issue in these patients, and we need to be aware of that these patients, because of the initial operations, because of the scars that exist in the heart, will have arrhythmias and will have a large proportion of cardiac death. And this has healthcare implications because it requires particular attention by colleagues with electrophysiological or arrhythmia expertise. Pregnancy is a big issue in this population. This is data from the UK looking into maternal mortality a couple of years ago. This is the period around 2020, and you see the main mortality reasons in mothers to be in the UK in that area was COVID-19. Of course, this has gone away now, but the second biggest killer for women with during pregnancy was cardiac disease. So we need to be very aware of that patients with congenital heart disease have a high mortality during a pregnancy. We looked at this issue in our cohort in Germany a couple of years ago, and we found a reasonable mortality for mothers, but a lot of morbidity in the mothers to be with congenital heart disease, and also a lot of morbidity and mortality for the neonates of mothers with congenital heart disease. So if a woman with congenital heart disease becomes pregnant, she has an increased risk of adverse outcome, but also her newborn, her fetus and her newborn will have a high risk of having congenital heart disease again, and also having a high morbidity and mortality. There are issues with infectious diseases in this patient with congenital heart disease that we have to be aware. This was particularly relevant during the pandemic, but is also relevant for other viral and bacterial conditions. So again, something to be aware of. So it's a lifelong condition. There is no cure for congenital heart disease. It can affect almost every organ system long term. And the consequence of this is, if you want to provide for patients with congenital heart disease, of course, you need a strong congenital team to care for these patients, but you also need a lot of other provisions. You need electrophysiology for the arrhythmias. You need cardiac surgery, of course, for the surgery, but also for transplantation. Later on, assist devices, you need anesthesiology, you need palliative care, you need interventional cardiologists, and then you need all other things like neurology and gynecology, etc., to care for these patients. And there are a lot of barriers to accessing congenital heart disease care. There's an excellent paper that I cited here that we need to discuss in terms of healthcare provision. There is delayed diagnosis due to home deliveries, maybe due to large family sizes, due to low caregiver education. There are difficulties in reaching treatment centers, of course, due to geography or lack of facilities. There may be institutional barriers because resources are mal-distributed. Social-cultural beliefs in many countries, female fetuses or female neonates are discriminated, are not proceeded to surgery as much as male neonates. There may be important financial constraints in this population. There may be insufficient trained workforce in this population, insufficient surgical or ITU capacity. So many things that need to be considered beyond screening in this patients. Skip this in the interest of time. And of course, if you think about appropriate provision for congenital heart disease, there are a lot of requirements in terms of human resources. You need to train cardiologists, electrophysiologists, surgeons, interventionalists, heart failure specialists, imaging specialists. That's an important issue that I want to highlight also for the infrastructure. You need to have good imaging. You need to have good diagnostic facilities to facilitate treatment in these patients. And this goes beyond the normal echocardiography. You need MRI, you need CT, you need advanced images in these patients to be able to provide state-of-the-art care in these patients. And only with this setup, we can provide adequate diagnosis, we can provide adequate therapy that is based on an appropriate diagnosis and improve survival in these patients. Of course, this is costly, this is difficult in terms of workforce, and we all hope that artificial intelligence and electronic means of the data communication will help us there, but that is obviously a different topic where we need to invest. So in conclusion, congenital heart disease is an increasing issue globally. It's a whole life problems. Patients are not cured by the initial operation. They require lifelong follow-up. adequate structures are needed. Cardiac and extracardiac complications are very common. We cannot just focus on the heart. We need to join forces to deliver better care for this evolving population. We need to centralize expertise, but that always means that you also need to ensure access to the centralized facilities, to the central tertiary centers. And you need wise investment into congenital heart disease because you need comprehensive structures that cover the entire life journey of patients. And I think patients are the true heroes here. They live with a very challenging conditions. And we have seen this in many of our patients. They are very stoic. They tolerate a lot of interventions throughout life. And good results can be achieved. It's a really rewarding experience. It's a worthwhile investment in this population, but it's not easy and requires good planning. And I would like to thank you for your attention. Of course, thank the IMA Stiftung Carla Völlm, the foundation that supports our work, that made our work at the Münster University Center possible over the last decade. Thank you very much.
Thank you.
And sorry for being slightly over time.
It is okay. We will manage at the end for the discussion. Thank you very much for Prof. Diller for the wonderful lecture that give us the insight that people with congenital heart disease actually will have a long life problems that we need to take care of and that will need a lot of resources in terms of the us as health practitioners and from the point of view of the healthcare system in a country. And so for the next, I think we will have another lecture about the congenital heart disease screening from Professor Matthias Sigler. Professor Matthias Sigler, he's a pediatric cardiologist and also intensivist, pediatric intensivist from the University of Göttingen. And we will listen to Prof. Sigler about the congenital heart disease screening. And I believe you will give us idea about the how screening system in Germany and how that performing screening probably will have a future impact in the care of adults with congenital heart disease as well. So Prof. Sigler, please, you have your time for about 15 minutes to deliver your lecture. I think you need to unmute your microphone.
Yes, thank you. Yes, sorry. Hello, everyone, and hello from Göttingen, actually. I will be in Münster later this year. I'm starting my position in as head of pediatric cardiology in October this year. So at this time, I'm here in still in Göttingen. So I just try to share my screen. I hope it works. Do you see the slides? Yes? Okay, perfect. So actually I see it on the other screen, but that will work anyway. I was asked to give some additional remarks on screening methods that are done in Germany to identify neonates or children with congenital heart disease. So it's not a full lecture of 15 minutes. So I give my remarks, and I want to give you an idea about the system and how it works in this country, in Germany. And I think some aspects are already mentioned, and it's important to acknowledge that the screening and identification of patients with congenital heart disease is just the start. It's just a beginning of the journey, and I think that was wonderfully illustrated by my dear colleague Gerhard Diller. So how does screening in Germany works? So the next slide. You already have heard that 1% of all newborns have a relevant congenital heart defect. So it's 1 in 100 newborns that need support and therapy during their life for a congenital heart defect. So 25% of these patients are considered to have a critical heart defect. That means a heart defect that needs medical intervention during the first year of life. Early detection that was shown improves survival and outcome in the long term for these patients. So there are basically 3 methods that are applied to detect congenital heart disease. And the first method, also time-wise, is already before birth. It's fetal ultrasound. So there are 3 time points in Germany where ultrasound is offered for free, paid by the public health insurance system. 3 time points where ultrasound is offered to the pregnant women, but it is basically meant to document fetal growth and development, and not especially to screen for heart defects. There is only one of these 3 ultrasound time points or dates, and that's the organ screening around the 20th week of gestation. But the fact, if really an organ screening is done, it's is not mandatory. It's on voluntary basis. So if the pregnant woman decides not to have the organ screening, it will not be done. So it's voluntary, and this organ screening, if it's done, it includes the cardiac four-chamber view, and also the great arteries should be visualized. And by this method, the detection rate is only 50 to 75%, depending on the experience of the examiner. But of course, only if the organ screening is done. The second method is basically auscultation. Auscultation during preventive medical examinations, which are offered on a systematic basis. You see the system which is applied in the German system, and I'm very sure that you have a similar system in Indonesia and in most countries worldwide. The so-called U1 is the first examination. It's done in the first hour of life. It should be done by a doctor, but it can be done by a midwife as well. And it includes auscultation. Auscultation does not necessarily identify a child with congenital heart disease. It's just the other way around. In the first hour of life, there are only very few children with actually a congenital heart defect, even if it's relevant, which can be identified by auscultation. And then you have the subsequent examination dates after about 1 week, after about 1 month, and then 3rd month, 6 months, and after 1 year. So during these examinations, you can, of course, identify children who have congenital heart disease, but not all the children will be identified. And in order to enhance the rate of identified children, especially with severe congenital heart disease needing urgent intervention, some years ago, oximetry screening was introduced in Germany. It's also mandatory. It's done between U1 and U2. So it's done within hour 24 and 48 after birth. It's also paid for by the health insurance, and it it consists of a measurement of transcutaneous oxygen saturation. As I said, it enables detection of critical cyanotic heart defects, which might be missed by just auscultation, and which might also be missed if an organ screening is done during the second fetal ultrasound. So how does the oximetry screening works? It's actually a pulse oximetry. So it's not only, or the documentation is not only the percentage of oxygen saturation, but also the quality of the pulse signal has to be documented in order to make sure that it was a proper measurement and that the value is reliable. So that takes sometimes 3 to 4 minutes until you have a good quality signal. So it's not just a thing of 10 seconds. And of course, you need a proper equipment. So an oximetry measurement tool that is of high quality. So if oxygen saturation is low, it's below 90%, then of course the screening is positive and children are sent to pediatric cardiology consultation. If it's between 90 and 95, it's repeated after 1 hour. And if it's okay, then the screening is negative. If then the oxygen saturation is below 96, there is a mistake. It should be greater equal 96, then it's negative. So if it's below 96 in the second measurement, when it was 90 to 95 in the first measurement, then it's considered positive, and all these children get a complete cardiology workup. As I said, positive children get the complete workup, including clinical evaluation, ECG, and most important, echocardiography. The statistical detection rate that is obtainable by this method is just, it sounds a small number, it's just 3 in 10,000 patients. So very few patients are identified. But these patients are the patients that might be easily missed by the other methods and really urgently need early medical intervention. And these are actually the most relevant heart defects, and early detection makes a big difference for these children in terms of survival and being able to grow up and to develop. So in summary, we have the 3 methods: fetal ultrasound, detection rate, altogether is 3%. If you taking into account that not every unborn child gets this organ screening, the obligatory preventive medical examination, auscultation during the follow-up examinations, reveals about 80% of congenital heart disease during childhood, but not always in time. So it might, or a child might have results of auscultation leading to detection of congenital heart disease, but at a time point where the first medical intervention should already have been done for a long time to prevent further problems of this heart defect. So neonatal pulse oximetry, the last of the latest method that was introduced, is able to detect just 0.03%. But as I said, only the most relevant heart defects will be found by this method. And since there are still some minutes left, I would like, if you want, I could just briefly show you one example of heart defects that are routinely found in pulse oximetry screening, which might be easily missed by the other methods. if that's okay, I just continue. And actually, it's the hyperplastic left heart syndrome. It accounts for about 3% of all congenital heart disease patients. So it's a little depending on the rate of fetal detection and abortion in a given population. So in our country, it's about 3%. In other countries, it's far less. It's sometimes between 0.03 to 0.5%. So nevertheless, hyperplastic left heart syndrome, here on the left, you see a schematic drawing, the normal heart, and you can appreciate that the left ventricle is hyperplastic. It's far too small. That's the basic problem. There is atresia of the aortic valve and the mitral valve, or one of the two, and severe hypoplasia of the and a severe hypoplasia of the aorta. So during the second week of life, there has to be either a catheter intervention, but in most centers there is extensive surgery performed. The whole aorta is reconstructed, and there is a shunt is created, autopulmonary shunt, supplying the pulmonary circulation, actually supplying the pulmonary circulation with blood. And during the second half of year, most of the time, and a next step is performed with connection of the upper cable vein with the pulmonary artery system, and the shunt is removed. And between 2 to 4 years, the Fontan circulation is created. That means the blood from the body is leaded to the lungs passively without a pumping heart chamber. And this one heart chamber, actually the original right ventricle, is now supplying the body with blood. And as Gerhard Diller already mentioned, these patients have, of course, high morbidity during a life and a limited life expectancy. But if done, or if identified in time, the quality of life can be quite good as compared to definite death during the first weeks or months or even some years of life if not detected in time. So this was just one example, and I thank you for your attention, and I welcome any questions that will be there later on. Thank you.
Thank you, Prof. Sigler, for your wonderful lecture and providing us with the situation, congenital heart disease screening in Germany, that actually you have the neonatal period of screening, or even fetal period of screening, right? And we will have this discussion later during the discussion session. And I think we will listen first to the status or the situation of screening in Indonesia that will be delivered by Professor Lucia Kris Dinarti. Professor Lucia Kris Dinarti is an adult cardiologist. She's a consultant of cardiology, and she's also a chairperson of Pulmonary Hypertension Working Group of the Indonesian Heart Association. And Professor Lucia will give us insight about the situation of screening in Indonesia, in particular the elementary school children screening. But maybe she also slightly will tell us about the neonatal screening, if it's possible, or just briefly, but mainly about the elementary schools screening program. Please, Professor Lucia, time is yours.
Thank you, Dr. Wulan, that already introduced me. And thank you to Prof. Laksono that invited me in this meeting. So my talk today is about implementation of early detection of congenital heart disease in elementary school children. Yes, as we know that congenital heart disease occurs in 8 over 1,000 of children in North America and Europe. And we know that congenital heart disease is the most common congenital disorder. And in general, based on heart flow, congenital heart disease are divided into 2 types: acyanotic. This is the defect that make flow from the left heart to the right heart. And cyanotic if the defect that cause flow from the right heart to the left heart. Yes, this is the Indonesian demographic and pH profile that we in Indonesia have more than 261,000 population, and we have 13 institution, state universities with associated hospital. But until now, we don't have national data on pulmonary hypertension. But since 2012, we made a registry named Cohort PH Registry in Sarjito Hospital, Yogyakarta, Indonesia. It is my hospital that we collected adult congenital heart disease. And currently, we already collected more than 2,000 patients, 2,200. And most of them are ASD in 67%, followed by FESC and PDA. And similar with other registry that most of them are female. In our registry is 76%. And most of them are come in reproductive age, 17 until 40 years old in 72%. And unfortunately, they come already suffered from pulmonary hypertension. So we also collected maternal heart disease in our hospital in 8 years, around 8 years. And we can see here that most of them are congenital heart disease. 53% are congenital heart disease, with majority is ASD followed by VSD and BDA. So this is the most common congenital heart disease in adults. ASD is the first, and then followed by VSD and BDA. So part of our registry already published in BMC in 2020, and from 1,000 of patients with congenital heart disease, from transthoracic echo, we found that 77% of patients already suffered from pulmonary hypertension. And after we perform right heart catheterization as gold standard for diagnosis of pulmonary hypertension, 67% of them are already suffered from pulmonary hypertension. So we know that in case of we have congenital heart disease, so if we find a patient with complication like a pulmonary hypertension, so this is need a lifetime medication, and we know that this is a very high cost for manage this patient. But if we find a patient without complication, so we can do defect closure either by surgery or by device closure. So this is the importance of early detection of congenital heart disease. So what we think is that the screening program in children is very important. So this is our challenge in managing congenital heart disease and pulmonary hypertension, especially that still many of us lack of awareness about pulmonary hypertension, then raise diagnosis of pulmonary hypertension also still lack. Then risk stratification and evaluation. We do not routinely do check NT-proBNP and also 6-minute walk test, and also availability of pH-specific drugs. So this is what we need to overcome our problem is make a screening program in a newborn, in a child, in a family, also in a pregnant woman, and also raise awareness to cardiologists about how to diagnose of pulmonary hypertension, and also approach to government. This is a Ministry of Health to provide pulmonary arterial hypertension drugs and a national formularium. So this is to inform you that drug availability in Indonesia, we only have 4 drugs out of 12 types of pH drug that already available in the worldwide. So this is a very limitation of us to give medication to patients that already suffered from pulmonary hypertension. So we know that the diagnosis of congenital heart disease, we need anamnesis, physical examination, chest X-ray, ECG, echocardiography, and also for the gold standard is right heart catheterization. So this is the ECG that we can see from patients with congenital heart disease, especially ASD. We can see the right axis deviation and right ventricular hypertrophy. And also we can see from the chest X-ray, we can see that there is an enlargement of the heart with overflow to the lung. And about the screening itself, where are we now? Yes, there are several studies that we see from several countries that they already perform screening program for newborn, for school age, and they do with several methods, echo, auscultation and echo, and also oxygen saturation, and we try, we think which one is better for us. So since 2012, we make a collaboration with Japan, especially with Kobe University, and they said that since 1985, they already do a screening program in Japan for congenital heart disease, and since pregnancy, then newborn, and year 1, 2, 3, and also in elementary school student, and also middle and high school. So we have to choose which one is better for us for initiating the screening program in our hospital and in our province. So after a long discussion with our government, so in 2021, there is a governor's regulation that screening, cardiac screening for children is important. So this is that we start to make a screening program in elementary school student. So this is the screening method that we make. This is we start with primary screening by general practitioner, and then using ECG, physical examination, and also oxygen saturation. And then if we suspect, then we refer the patient to the cardiologist to do echocardiography. And after we suspect, then we send to the tertiary center hospital to confirm the diagnosis, and then to close defect in case that there is still closurable either by surgery or by device closure. So we start with a general practitioner workshop to give lecture and also refreshing to how to ECG interpretation. And then we start to make a screening using physical examination, using oxygen saturation, and also using 12 ECG for patients, for students. Then after that, there is difficulties to implement this method. Lead compared to 12 leads.
I think there's a notification that the microphone is off from some of the audience.
Okay.
Okay, please continue.
Okay, so thank you. This is our result from the first screening in a primary school student, involved more than 6,000 of children, and using auscultation and ECG, and we found 45 of them have a murmur, and have 200 have electrocardiography abnormalities, and from them we find 7 patients with abnormality of congenital heart disease and valve abnormalities. And in 2022, we also tried to make a screening program in more than 600 students with auscultation and with ECG, and we find that 78 patients have a right axis deviation. Then we also find that one of them have a murmur, and we find 1 patient with a secundum ASD. And again, in 2023, we tried to make a screening in 100 patients, and we find also there is a right axis deviation and also arrhythmia. So this is what we built in our province to make a screening program for congenital heart disease. First is primary screening with ECG 6 leads done by the teacher who responsible to the healthy student. And then if there is an abnormality from 6 leads, right axis deviation, for example, so we send to the primary healthcare to do 12 leads of ECG. Then the doctor also do auscultation and also oxygen saturations. Then if they suspect that there is an abnormality, so that they will send to the secondary screening to the cardiologist to do echocardiography. And again, that in case that there is an abnormality, so they will send to the tertiary tertiary screening to confirm the diagnosis, and then do treatment or manage by closing the defect, either by surgery or by device closure. And this is my last slide, that currently we try to make a national registry for pulmonary hypertension, and from the result that still not so much, that the problem is similar, that most of them are congenital heart disease as the background of the underlying of the pulmonary hypertension. So this is my problem. So what we think is maybe the screening program for children is one of the solution to early detection of congenital heart disease. So I think this is my slide. Thank you very much to our assistant that makes our registry happen within 12 years. So thank you very much.
Thank you, Prof. Lucia Kris Dinarti, for your wonderful lecture about the situation of elementary school screening. And we're now come to the discussion session. I would like to invite if there's any question from the participants or any discussions from all the speakers. Or before, I noticed here that we have our pediatric cardiologist in our center, the lead of pediatric cardiologist in our center join us. Professor Indah Kartika Murni has joined our session, and she's the lead of pediatric cardiology in our university. And actually in our country, we have also the newborn screening program approved by Ministry of Health. And I would like to introduce Prof. Indah to Prof. Sigler and also Prof. Diller and also Prof. Rasjid. Here, Prof. Indah is present with us. And maybe Prof. Indah, can you just briefly tell us the situation of newborn screening in our country that has been approved in the last 2 years?
Yeah. Okay. Thank you so much, Dr. Bulan. Yeah. Can you hear me clearly?
Yes.
Yeah. Thank you. So thank you very much for Professor Sigler, Professor Diller, and also Professor Rasjid for nice lecture. And actually, since last year, Indonesia has been conducting a pulse oximetry screening for newborn. It is actually initiated following the provision of local data from Dr. Sarjito Hospital, which is it is similar with a hospital that has been mentioned by Professor Kris Dinarti. And our studies at the time actually revealed that around 60% of children with congenital heart disease were lately diagnosed. And it is very surprising that around 85%, so 8 to 9 patients with critical congenital heart disease were lately diagnosed. So and that's why at the time then we conducted a feasibility study at the time across 4 hospitals in Yogyakarta province and recruited around 2,500 births, and then we conducted this screening for critical congenital heart disease, and we found around 10 positive result for the screening positive for the pulse oximetry, and then 8 was confirmed positive with the echocardiography. And since then we advocate the Ministry of Health and a nationwide screening program was implemented across Indonesia since 2023. And then they did, and also with the Indonesian Pediatric Society, we did the training for all the health workers, including the midwife, nurses, and also doctors. And also the Ministry of Health also distributed around more than 10,000 infant pulse oximetry to primary health centers as well as the district hospital to support this initiative. Yeah, I think that's all. Thank you.
Thank you, Prof. Indah. Prof. Sigler or Prof. Diller, do you have any comments on the situation of the newborn screening or the school screening in our country?
So actually,
experience.
So actually, thank you very much, and thank you for this this edition. Actually, you have a very similar system. So it's following the recommendations from the World Health Organization, and I think it's very parallel. And I wonder what is the status of fetal detection of congenital heart disease. That's a problem in our country actually, and many, or in my eyes, too many children, newborns with congenital heart disease are missed during fetal screening. So our care could be much better. And what is your experience in your country, Professor Moni?
Yeah, thank you, Professor. So actually, it is quite similar with our setting in Dr. Sarjito Hospital. We also rarely done the routine fetal echocardiography because, as perhaps, if I'm not mistaken, the indication also it's only 3%. We sometimes do this fetal echocardiography, for example, if the mother or the father having the congenital heart disease, as well as if there is any systemic lupus erythematosus, or perhaps there is any problems in the conduction system, then we will do. And sometimes it is also difficult to do this fetal echo. So that's why if there is any uncertainty, then the OBGY doctor, they will send to us for pediatric cardiologists also to do this screening together. Yeah.
Yeah, very good.
Yeah, thank you, Prof. Indar, for the introduction. And maybe Prof. Kris, do you have any additional comment on this, or no?
No.
Okay. Maybe I would like to ask that if you notice from the slides of Prof. Lucia that we actually face a lot of burden of uncorrected adult with congenital heart disease, and especially ASD. And yeah, we all know that ASD is quite difficult to diagnose during childhood, especially during newborn. It's other than the echocardiography, it will be missed. And what is the strategy in your country? And I noticed actually, Prof. Diller, from your paper, you don't have a lot of uncorrected congenital heart disease anymore during adulthood in Germany. And actually, how did you have the system to prevent the late diagnosis for the untreated congenital heart disease during adulthood?
Yes, thank you. That's an excellent question. I think there are different aspects here. So one is the neonatal screening or the prenatal screening, where you want to pick up the complex critical conditions that need to be addressed immediately after birth to enable the children to survive. There are duct-dependent lesions, very complex lesions, where the surgeons need to, or the pediatric cardiologists need to go in early and enable these children to survive. And then, as I said, these patients are by and large doing well and surviving into adulthood, but they're not cured. And then there are other conditions that manifest themselves later. And a good example is, of course, the ASD or other simpler conditions. And of course, they have a little bit more time for detection. So I think the school screening that you do is mainly addressing this proportion of patients where you sort of have conditions that manifest themselves later. We do have the same situation in Germany, of course, that there is data on adults who present with congenital heart disease to the adult cardiology department. And the most common condition in adulthood to be picked is the atrial septal defect or the anomalous drainage of the pulmonary veins that sort of, becomes symptomatic later on. Some of these patients become symptomatic because of heart failure, some of them because of pulmonary hypertension or arrhythmias or other issues. So it's not that you can detect all conditions immediately after birth, as you say, and so you need to have a multi, a stage strategy. So you need the immediate postnatal screening and the prenatal screening for the critical conditions. You need the screening during the pediatric time, and of course you need to be aware during adulthood. So of course, I'm not aware of the situation in other countries, but in Germany for sure there is no a systematic screening process for congenital heart disease in adults. These patients are picked up by general cardiologists or general physicians because patients present themselves with some sort of problems. Some patients may be picked up during pregnancy or screening for pregnancy or for other reasons, sort of incidental findings on imaging, but by and large, these patients present with symptoms. So this is something, yes, that you're correct, and we need to be aware of.
Thank you. Speaking about pregnancy, do you have the comprehensive screening for pregnancy, including the cardiac situation of the mother?
No, there is no systematic screening for congenital heart disease. Of course, we would hope that most women that are born with congenital heart disease and want to become pregnant should know about, at least they should know about the fact that they had some heart condition and should make their physicians aware about this fact so that they can get some information or get some additional investigations done. But we do have patients that become pregnant, and we are then surprised, and we are presented with these patients during pregnancy, including mostly it's simpler lesions, but it also includes complex lesions like even pulmonary hypertension during pregnancy or Eisenmenger's. Very rare, but you do have this situation, and that is, of course, a very challenging situation for everybody, because in some of these women, as you might expect, we have to advise against continuing pregnancy, and that leads to very difficult discussions, of course, with the family about what is the best way to go ahead, whether to prioritize the safety of the mother, or whether you want to continue with the pregnancy despite the risks that are inherent to this condition. Of course, this affects mostly pulmonary hypertension and some of the very complex congenital conditions. But this is a very difficult topic. No, but the short answer is there's no systematic screening process for women who want to become pregnant.
Thank you. It's very interesting. And we will never finish discussing about the pregnancy with a lot of problems, cardiac problems, I mean. I think Prof. Laksono will have some comment or discussion about this.
Yes, thank you, Bu Wulan. So, Prof. Sigler, this is a question about the use of the ultrasonography, USG, for detecting or screening heart disease. Is there any special training for GP or nurse to do the screening using ultrasound? And also for Professor Indah from Sajito, are you still there, Prof. Indah?
Yes, Prof. Laksono. Yeah.
Yeah. Is there any plan to have USG as one of the screening tool in Puskesmas? Because actually at the moment, the government deploy for every Puskesmas ultrasound USG. Is there any program for this? Okay, thank you.
Yeah. So it is me first. Okay, thank you. Thank you, Prof. Laksono. So actually in Indonesia, we also have followed up for the pulse oximetry screening training. So it is conducted by the midwife, nurses, and also the general doctor. And if it is positive, then we have started to give the training for the pediatrician actually for doing the echocardiography. It's only the basic echocardiography to see whether this positive screening, which is it is really critical congenital heart disease suspect or it is normal. So it is the training. It's only to see whether it is normal or not. And if it is perhaps it is normal or not, then they will consult to pediatric cardiology using the application. It is Prima Pro. It is also provided by the Indonesian Pediatric Society. So it is also arranged by the Ministry of Health now to do the training for the echocardiography for the pediatrician. Yeah, in all Indonesia. Thank you.
Okay, I may add some the situation in Germany. So if a child is detected maybe by auscultation or by the neonatal pulse oximetry screening, then it is sent to a pediatric cardiology consultation. So it will be seen by a trained pediatric cardiologist. So we are so happy that, or so lucky to be able to provide this type of examination to all children. It means I mean it means a travel of usually just a couple of kilometers or miles for the families. In some instances, it might be like 80 or 100 kilometers, but not more. That might be much different, I guess, for you. But so they will have a screening of a pediatric cardiologist right away. Coming back to the fetal screening, if an organ screening is or the wish of the pregnant woman or the family is there that an organ screening is should be done, then the gynecologist, the obstetrician, has to have a special qualification to perform this with a high quality. So for just documenting development of the fetus, you don't have to have a special training, but for the organ screening, you must be must have a special training. Otherwise, you are not allowed to refund it by the health insurance. That's the system.
Okay, thank you.
Yeah, thank you, Prof. Laksono, Prof. Sigler, and Prof. Ita. So maybe a question again to Professor Lucia, and also I want to comment the comment from everybody here that your elementary school screening program is actually to take the unscreened congenital heart disease that is being done by the neonatal period or by the professor in the program. And we know that screening is always a Swiss cheese problem, that whether someone is screening and there's always people or kids who are passed through the screening. Do you think the elementary school screening program is enough in that one time, or do we need to like screen in other period of the pediatric period, like the high level of elementary or junior high school or senior high school? So what's your comment?
Yeah, thank you. So this is, I think, the first project for elementary school screening, Dr. Wulan, because we know that in Indonesia, we don't have such screening. So we just try in which age we can start to screen the student. I think that if only in one time, so I think many cases will lose. So it's better if we can do screening for in a period. First is in first stage and in 6 years old. Then after that we will screen again in 10 years old, and then in mid school, and also then in high school, and all, because we know that we still look for the tools that can detect the congenital heart disease, Dr. Wulan. So I also asked to Prof. Diller or Prof. Sigler, what is your suggestion about the tools that better than what we propose in our screening program?
Yes, to comment on the pediatric side.
Maybe I just yeah, a short comment maybe. I shortly showed you the system of routine systematic checkups for every child, and during any routine checkup, an auscultation is provided. But that's basically all what is done for the heart. And everybody knows that not all congenital heart disease or congenital heart defects produce a heart murmur. So some of the children or some of the patients are missed by this method, but most patients are found because it's not only auscultation but also asking for problems, and there might be hints like palpitations that the patient feels, or there's a family history indicative for a heart problem, and then of course that would be a reason to proceed with a specific workup.
Yeah, and maybe just a short comment from my side. So I think the other thing that I didn't discuss in the interest of time, and of course this is just food for thought. I guess there is, of course, interest in the future to try to use technology for screening. So the question is, if you are to invest into new programs, I understand that Indonesia is 4 times as big as Germany in terms of size. It might be at least something to consider how you could use technology and remote screening of patients. And there are some projects that have been sort of contemplated where you can use handheld echocardiographic devices, for example, that are linked to the internet or to mobile transmission, that are then transferred to a central institutions where they can be reviewed, or hopefully in the future even subjected to some sort of machine learning algorithms to screen patients. I think that's obviously not happening now. I don't think it's happening anywhere in the world, but I think this is something where investment should go to enable sort of screening and even remote areas.
So thank you.
Okay, thank you. That's I think that's a brilliant idea, but yeah, given the situation of Indonesia with 280 million population, probably the self-reported ECG remotely probably one of the idea, because now the portable ECG or patients derived ECG monitoring is available, and that will be probably a good idea for the future. But of course, again, it's back to the literacy of the patients itself, or our people itself. And I think because of the time, we still have some questions from the audience.
Yeah.
And
Dr. Dia,
oh,
Dr.
yes.
Wulan, I have a
Prof. Rasjid.
question.
Yes.
Yes.
Okay, please, Prof. If you have any discussion.
Thank you very much. I have a question for Professor Laksono and Dr. Lucy. You know, I am a former cardiac surgeon in UKM for a long time, and I have performed operation in National Cardiac Center in Jakarta and in Yogyakarta for a long time. My question is, this topic is very, very important. The screening for cardiac disease is very important for children, for adults. My question is, these children need for surgical treatment. And my question is possibility to train people in Germany? Because I have 3 assistants, former assistants for me in Bonn, in Bremen, and in Leipzig. Maybe we can send people from Gajah Mada to train for pediatric cardiac surgeon in Germany. Is that possibility, Professor Laksono or Professor Lucy?
Yeah. Yes, I think
Thank
it's
you.
very possible. Yeah. In Sarjito Hospital, in Sarjito, in Gajah Mada University, the training for cardiac surgeon is just started, Prof.
Yes.
So maybe we can send them to Germany, for example, to do the fellowship for cardiac surgeon.
Yeah. Okay. Can you hear me? Yes.
Yes.
Okay. Yes, Prof. Rasjid. Yes, I think the idea of having like a professional link between Germany and Prof. Kris mentioned and Sarjito is very, very logical. And using the new law, the new head law 2023, it is possible also for if some surgeon from Germany, they come to Indonesia for having a surgery and transfer of technology or transfer of skills, it is possible, but it should be prepared in detail. And also for sending like fellows, yeah, Prof. Kris, yes, to Germany, we try to find fellowships for doing this. And there's a new policy for providing fellows with fellowships, yeah, to overseas centers of training. Yes, I think this is very, very open to be explored, and hopefully after this meeting, we can have like a small team for doing this. Thank you.
Thank you.
Thank you, Prof. Rasjid. I think it's a wonderful opportunity for us, like Dr. Kris and Prof. Laksono. And can we open questions from the audience? I think we have 4 questions, but maybe due to the running of time, we can, I will screen some of the questions that probably will give us a big impact is to Prof. Diller. The congenital heart disease patients, when the transitioning from child to adult is a big challenge, especially a big challenge in our country. So do you have any idea how we can start to comprehensively handle this transition from pediatric to adult patient based on your experience in Europe, Prof. Sigler and Prof. Diller? The second question.
Well, I think it's a challenging question. I try to be brief in the interest of time, but I think the most important thing is to create awareness, to educate parents and patients early on that this is an important issue. So because they need to be the advocates of their own health, and they need to take care of their own health long term, and they should be aware that they need lifelong care. And of course, then pediatric cardiologists and ACHD cardiologists, from what background ever they come, need to work together so they make sure that they hand over patients appropriately. But as you've seen from the slides, it's an unsolved problem everywhere. I think the most important things that I can say is education, create structures, create awareness, and work together. Those are the 3 things that I think are important.
Do you have the special clinic in your institution for that, in your hospital?
Yes, we do work together with Professor Sigler's department so that patients are then handed over when they reach a certain age, and they have joined clinics where they see both their pediatric cardiology colleagues that they know for a long time, and the new carers that they are supposed to see in the future, so that they are made familiar with the new structures. That's what most centers try to do worldwide, to have this sort of joint presentation. It doesn't always work because of logistics, because of various reasons, but that is the aim, and definitely we hand over patients in a structured way. So that is an important issue. Yeah.
Thank you. And the second question is from for Prof. Sigler. The participant would like to ask what is the best time to do fetal echo if we only have one chance? And do you have fetal echo only in specific indicated population, or do you do it in every pregnancy or routine pregnancy screening?
Actually, the best time point, in order to optimally detect heart's abnormalities, you would head for like as late as possible, means within the time range around the 20th week. You would rather go for the 23rd or 24th week. But if you want to have a basis for a possible abortion, you should be earlier. So it's difficult, and you only have one chance. It's the same for both countries, I guess. And so the time point where you get the organ screening, but as I said, it's voluntarily, it's paid for, but the family has to ask for it. So the time point is around the 20th week. So it can be the 18th week, it can be the 22nd, 23rd, or even 24th week. So I think the optimal time point is 22nd week. It's before the child can survive because of prematurity. The ability to detect the heart properly is fair. It's okay. It's much better than in the 18th or even earlier 18th week.
Thank you, Prof. And I hope that answer your question, Dr. Ahmad Bima. And yeah, due to the interest of time, I think with regret, we have to close the lectures and also discussion since we have our last agenda of the closing remark from Prof. Rasjid. And I would like to thank all the three distinguished speakers and also Prof. Indah for joining the discussion. And well, big applause for everybody. And I really hope that from this meeting forward, we can continue our collaboration in the next future. And thank you very much. I would like to return the time to the Master of Ceremony, I think, for the closing remark from.
Well, thank you very much, Dr. Dia, for the exciting session that you have guided today. And now would like to proceed, ladies and gentlemen, to the closing remarks, and would like to honorary invite Professor Rasjid Soeparwata. To Professor Rasjid Soeparwata, time is yours.
Thank you for giving time. First, my congratulations to the speakers, to their excellent presentation, and thank to the audience for interest. By this webinar, for the first time, UGM and UKM share knowledge in the field of congenital heart failure, and hopefully this cooperation will continue in clinical scientific area. Next, please. Next slide, please. Cooperation like this needs help by the government, universities, participation of all interested medical doctors, health insurances, and especially dedicated personalities like His Excellency Professor Laksono, Trisnantoro, His Excellency Professor Ismunandar, UNESCO Ambassador in Paris, and Mrs. Carla Fulm, Honorary Consul of University of Munster, who supported the EMA Center. I mean, adult with congenital heart failure in Munster as an example for private founders. Next slide, please. The cooperation like this are only successful when regular and continuous meetings are planned and organized. An interdisciplinary joint working group is necessary to improve the result of medical treatment. Next. As example, I want to show you my grandson suffering from critical congenital heart failure. After closing atrial septal defect, correction of the hypoplastic aortic arch and aortic isthmus stenosis, end-to-end anastomosis using cardiopulmonary bypass.
We would like to extend our gratitude for the time that you have attending this session in webinar for cardiovascular disease and screening between University of Munster, Germany and Universitas Gadjah Mada, Indonesia. And looking forward to have another session. And it is very pleasure for us to guide this session. And thank you very much for your time and see you around. Goodbye. Thank you.
Thank you.
Terima kasih, Prof.
Ya,
Terima kasih.
makasih.
Terima kasih, Prof. Terima kasih, Dr.
Ya,
Ulan. Ya.
Maaf ya,
semoga
Mbak
terus
Ida.
ya, terus berhubungan dengan mereka ya.
Ya, matur nuwun, Prof. Monggo.
Terima
Ah,
kasih ya,
nanti
Mbak
Terima
Ida.
kasih,
Maaf
Prof.
ya.
Ya, nggak apa, Dek.
Saya
Terima
Mbak
kasih banyak.
Gerhard-paul ya.
Jadi dikunjungi aja, dikunjungi ke Munster ya. Oh, ini ada dari Kemenkes ya, Pak Bu siapa nih?
Siap, Prof. Penta, Prof.
Oh, Popenta ya, iya ya. Ya tadi saya sudah lapor Pak Menteri juga. Ini cara kalau misalnya kita mau mendatangkan juga